All right. Well, welcome everyone. My name is Kelly Wells Sittig, and I have the honor of serving as the Executive Director of the Iowa Cancer Consortium. We all here at the consortium want to thank you so much for taking time today to be with us. We have a really packed agenda for our time together, so I'm going to start by asking everyone to introduce themselves in the chat, if you would. Joining us on Zoom are also members of our board of directors, staff, as well as the Iowa experts who have agreed to share their cancer relevant knowledge with us today. I think we are all likely here because we know that the burden of cancer on Iowans is too high. Cancer is so complex and there is no simple fix. But as experts in the field, we are confident that there are things we can do to reduce the burden of cancer for the Iowans we serve. The Iowa Cancer Consortium board, staff, and partners, again, are so grateful to you for taking time to be here, and for those of you who are watching this later, and for recognizing the important role that political leaders play in helping to reduce our cancer burden here in Iowa. We do plan to follow today's presentations with a survey to all gubernatorial candidates so that we can better understand your plans for addressing cancer in Iowa if you're elected governor. We want to make sure you have access to accurate information and resources to help you develop policy priorities. So I hope you'll take advantage of the expertise available today to ask questions. And we also hope our conversations won't end today. The Iowa Cancer Consortium, our partners and experts are all here to be resources for you. And I do want to mention that the Iowa Cancer Consortium is a non-political, nonpartisan, and non-lobbying organization. We are here to be a resource for you and others working in cancer control. Here is what our time together looks like today. In a moment, I will talk very briefly about what cancer control is and what it looks like in Iowa. And then Dr. Mary Charlton will provide an overview of Iowa cancer and risk factor data. Dr. David Swartney will talk about water quality. Dr. Whitney Zond will present about access to cancer care. And Dr. George Weiner will talk about cancer research. And then finally, I will share some information about the Iowa Cancer Plan and we'll open things up for questions and answers. And a note, we are recording today, but we will stop the recording during the question and answer period so that you can all feel free to ask questions openly. That portion will not be shared with the public. I also want to note that it would be impossible for us to cover every important cancer topic in an hour and a half. So the topics that you'll hear about today from our experts are not at all the only important ones when it comes to cancer control. In fact, one of the biggest things I hope that you'll take away today is that controlling cancer is wildly complex, and we have to be prepared to address it from many different angles, at multiple levels, and for the long term. We chose our topics today because they are foundational to cancer control and/or because they are of special interest to Iowans at the moment. And we want you to have the accurate information you need to make policy decisions around them. As I've already said, cancer is complex. Whether we're talking about an individual case or we're talking about it at a population level. It is also an incredibly costly disease in dollars, in years of life, in quality of life. And because of this, comprehensively addressing cancer requires that we all work together. And that's why you'll see that collaboration is a theme throughout cancer control itself and throughout the work of the Iowa Cancer Consortium. At its most basic, the goal of cancer control is to reduce the burden of cancer. You'll likely hear us talk about reducing the burden quite a bit, and I want to clarify what that means. I really like how the American Cancer Society defines it here, and that is reducing the burden of cancer means preventing cancer and decreasing how cancer impacts populations, communities, families, and individuals. Cancer control itself involves a wide range of activities that span a continuum from reducing cancer risk and preventing cancer as much as possible to finding it at its earliest and more treatable stages, to ensuring that every Iowan has access to the very best treatment and care and the highest quality of life throughout their cancer journey and beyond. Across this continuum of prevention, early detection, treatment, and quality of life, there are numerous other factors at play, including collaboration across sectors and even across traditional competitive boundaries. Cancer control is also based in scientific evidence, and it involves policy and systems change for population level impact. Just over 2 decades ago, the CDC established the National Comprehensive Cancer Control Program, which actually led to the development of Iowa's first cancer control plan. Today, the Iowa Department of Health and Human Services, the Iowa Cancer Consortium, and numerous partners work together to implement what we refer to as the 3 Ps. The program, which is the Comprehensive Cancer Control Program housed at the Iowa Department of Health and Human Services, the partnership, which is the Iowa Cancer Consortium here in Iowa, and the plan, which is the Iowa Cancer Plan. And I'll talk more about the Iowa Cancer Plan towards the end of our time together today. The Iowa Cancer Consortium, then, is Iowa's nonprofit cancer control partnership or coalition. We are a 501(c)(3 funded in large part by a competitive contract from the Iowa Department of Health and Human Services. Again, we are a non-political, nonpartisan organization and do not engage in lobbying. The consortium's role is really to help Iowans develop partnerships, find funding, and build skills and knowledge to reduce the burden of cancer together, again, with that focus on collaboration. We convene statewide work groups of experts and key partners. We fund local cancer control work. We develop the cancer plan, and we build partnerships. Right now, more than 700 members and 70 organizations across the state are members of the consortium. And I think this really shows how much interest there is in working together to address cancer right now. Members include cancer centers, local and state public health, nonprofit organizations, cancer survivors, caregivers, advocates, policymakers, and many more. And we invite all of you as Iowans, as candidates, as current and future policy leaders to join us in this collaborative cancer control work. We all know that there are many ways that individual people can work to address cancer in Iowa, but we also know that making changes to systems and policies at all levels, including at the state level, has the potential for the biggest impact. And I think that's why it's so important that you're here today. Iowa has a wonderful cancer control infrastructure, and I think if you asked many of the folks on our meeting today, it is one of the best in the country. You have such a critical role in addressing cancer in Iowa, and we want you to know that this cancer control infrastructure and that our cancer control partners are here to help you. So with that, we're going to get started with our speakers and hearing from our experts. First up is Dr. Mary Charlton, and I'm going to ask our speakers to give a very brief introduction of themselves as well. Dr. Charlton?
Great. Thanks. Can you all see my slides there? Make them bigger?
We see the slides view, not the presentation view. There you go.
Okay. Hi, everyone. My name is Mary Charlton. I'm a cancer epidemiologist at the University of Iowa College of Public Health and director of the Iowa Cancer Registry. I have lived in Iowa now longer than I haven't. I was actually born in Omaha. I've only ever lived on Interstate 80. That is an interesting fact about me. Maybe someday I'll go south, but I think the Midwest might be the place to stay. So anyhow, we start off all of our presentations at the Iowa Cancer Registry with the quote that statistics are people with the tears wiped away. We're going to throw a lot of numbers at you today, but want to assure everybody that we always think about the people and the families and the lives that are behind these numbers. So maybe you've heard that Iowa has the second highest cancer rate in the country. This rate is 14% higher than the rest of the US. What's concerning is that, Iowa's rate continues to grow. That kind of lighter line here for Iowa is sort of the smooth projection based on the cancer rates can kind of jump around. So Iowa is one of only a few states that currently has a rising cancer incidence rate. It's really the only state that's had a consistently rising rate over the last several years. You can see, whereas the rest of the United States is either sort of flat or declining over time. And so there's been quite a difference in the shape of our trends since about 2013. The good news, and there is going to be some good news in my presentation, is that our mortality is not different by and large from the rest of the states in the country. We're kind of middle of the pack. We have the 23rd highest rate of cancer deaths in the United States. It's about 3% higher than the US rate. You can see we kind of crossed over here again in kind of that 2010 plus time period, but cancer mortality is decreasing similarly as in the rest of the United States. And so I'll kind of talk through the slides. I think the theme of today might be a nuanced discussion of what's going on today. As you are all aware, I'm sure people would like to reduce this down to one thing. and the fact of the matter is that it can't be reduced. And there is some good news in with the bad news of our cancer rates. So we're going to talk about all of that. I just wanted to point out that this data is possible to show because of the Iowa Cancer Registry, which is funded largely by the National Cancer Institute. 80% of our budget actually comes from the NCI. So in the state of Iowa, we're really fortunate. We were one of the first cancer registries in the country to be selected as part of NCI's program. Because of that, we have data for going back for the past 50 years. We also largely get our cancer registration. Every state has to have a cancer registry. Ours is largely paid for by the National Cancer Institute, which is great. And our goals are to assemble and report data on new cancers, cancer deaths, and survival. We respond to data requests from organizations and individuals. That includes people concerned about cancer clusters in their area, different things like that. And we support studies for cancer prevention, research, and education. So we collect this data so that others can use it for research, for public health practices. But our focus at the Iowa Cancer Registry, we are a surveillance organization. We're not a research organization. You can imagine that as we report these numbers and report this information, people kind of tend to think like we are also the ones solving it, which we certainly want to be part of the solution and help with our data, but our scope is largely surveillance. So as I mentioned, cancer is very complicated. There is no one cause of cancer. It's a combination of different genetic, lifestyle, and environmental risk factors that change the way our cells function. The sort of sad fact about cancer is that even with no exposures, anything else, if there were no other causes of death, we would all eventually die of cancer. The longer you live, the more opportunities your cells have to make mistakes as they divide. And that's what leads to cancer. But there are many things that can speed up that process. And those are the risk factors that I'll talk about a little bit later. There can be many years between exposure to risk factors and cancer development, which makes it difficult to prove connections. For example, lung cancer may not occur until 30 years after a person starts smoking. Also, risk factors work in combination with each other. They don't work alone. So I think this leads to a lot of frustration from people of why can't we just figure this out? What's the thing causing all the cancer in Iowa? When you look back at that graph, I showed you that things started to change in 2013. So people often ask, what happened in 2013? Is there some new exposure, some new thing? The reality is probably nothing happened in 2013. Maybe things happened over the last couple of decades that have led to a change. So it's not, you're not looking at exposures now, it does not explain our cancer rates now. Okay, so there's a lot happening on the slide. I just kind of want to walk you through it here. These are on the left-hand side where it says rank, that's how we rank compared to other states in all these different common types of cancer. So we rank first in our incidence of oral cavity and pharynx cancer, so head and neck cancer. We rank number 2 in leukemia. We rank number 3 in non-Hodgkin lymphoma, number 4 in melanoma, number 5 in esophageal cancer, 6th in uterine, or also known as endometrial cancer, 7th in bladder, 8th in colorectal and kidney cancer, 13th in lung and prostate cancer, 15th in breast cancer. These are most of the major types of cancer there are, and they all have very different risk factors associated with them. The ones in yellow are the ones that are the most common cancers in Iowa. You can see that their incidence rate is represented by the bar here. You can see these are the most common. They have the longest bars. And in all of them, this black line represents the United States, and we are significantly higher than the rest of the U.S. in every one of these types of cancers. Just a quick note here about pediatric, adolescent, and young adult cancers in Iowa. Those are very much on people's minds. I would certainly argue that any number of cases of cancer in this age group are simply too many. And fortunately, in Iowa, we do not have a higher rate of pediatric or adolescent cancer compared to the rest of the United States. We are very similar in our rates. The trouble starts, and in terms of trouble, I mean where we have a significantly higher rate than the rest of the country, begins in that 20 to 39 year age group, the young adults, where you can see we do have a significantly higher rate in Iowa compared to the rest of the United States. Just a little bit about geographic distribution, where we see high rates in Iowa. These are some cancer zones that we created in collaboration with the National Cancer Institute. The darker the purple, the higher the rate. The lighter the yellow, the lower the rate. So you can see that for all cancers, all ages, you don't see a lot of patterns. There's a few clumps of zones here together, some around Des Moines, but you see some urban, some rural. The map on the right is ages 20 to 39, which is a little bit different pattern where we see the highest rates of that. There's some similarities, but you don't see just one whole section of the state as dark purple there. And then next you can see that pretty much all those common types of cancers that I mentioned in the previous slide, there is not a pattern that we've looked to try and figure out across these different cancer types, are there similarities? You can see breast cancer tends to be highest. The rates tend to be highest in the metropolitan or urban kind of areas of Iowa. One factor in this is that in general, the more educated women are, so the rate of college education in a given area tends to be associated with the age at which women have their first child. And that's important because the older you are when you have your first child, the higher your risk for breast cancer related to exposure to hormones. So where the more educated women live, those areas tend to have higher rates of breast cancer. So those are in our urban areas. Colorectal cancer is the opposite. You see a lot of rural areas in purple. Sometimes that has to do with access to colonoscopy. Colonoscopy is really one of the only cancer screening tests that can actually remove a polyp before it becomes cancer. It's actually preventive in addition to a screening test. So the more access issues you have to getting something like that, sometimes the higher the rate. Prostate cancer, we've always seen a little bit higher in Northwest Iowa, also in Northeast Iowa. Lynn County tends to come up in some of our analyses. Melanoma seems to be a little bit higher in the north and kind of along the river. Lung cancer, complete opposite, higher in the south, along with some of these other types of cancer. So you can see it's very different for each type of cancer. Okay, so this slide is related to the work that we're doing from the allocation from the state legislature, which we're part of, where we set out to figure out, okay, all these rates, like what does that mean in terms of people? How many more Iowans are diagnosed with cancer because of our high rates? Like how many people in Iowa would be diagnosed if we had the same rate as the rest of the country? So if you look here in this column by cancer site, we have 2,898 cases of prostate cancer in 2022. So that's our most common, followed by breast cancer, lung cancer, colorectal cancer, melanoma, and then we combined all other cancers here for a total number of cancers of 20,615. And I'm saying cancers, and I'm not saying people, because sometimes our people get diagnosed with more than one cancer. So this is each of the cancers they're diagnosed with. So these top 5 cancers, which we talk a lot about for good reason, they account for 55% of all cancers. So now if we compute out, what if we had the same rate as the rest of the country? We didn't have the second highest rate. We just had this average rate. We computed how many people in Iowa would get cancer. And you can see it's quite a bit lower. We'd only have 18,000 people instead of 20,000 people getting cancer. So it's a difference of 2,582 Iowans who got cancer above and beyond what would have happened if we had the same rate as the rest of the country. And you can see we computed that for each cancer type. So we think we have 331 excess cases of prostate cancer, 141 excess cases of breast cancer, 376 excess cases of lung cancer, which is one of our most deadly cancers, accounting for 25% of all cancer deaths in Iowa. 189 excess cases of colorectal cancer and 400 excess cases of melanoma. And these all account for 56% of all excess cancers in Iowa. So that's why we tend to focus on these top 5 so much, but not to discount the importance of the other cancers contributing to this. Again, this is also from that analysis where we set out to figure out, well, if we look at states that have similar demographic characteristics, similar behavioral characteristics like smoking rates, drinking rates, obesity rates, things like that, we looked to see which states had those things kind of in common and came up with the statistics team that we're working on for that the project, Cancer Drivers Project from the state legislature allocation, came up with this map, and we found that we're similar in demographic characteristics and behavioral characteristics to these other states. We may be similar to them in lots of other different ways too, but just focusing on that these are states with similar profiles to Iowa. And so we then looked to see, well, do we have excess cases compared to them? Do they also have high rates because they have these similar demographic characteristics and behavioral characteristics? So this is basically showing when we compared ourselves to the US, we had 141 excess cases of breast cancer, and that went, almost a third down compared to our neighbors. Then we only had 64 excess cases, still too many, but less than 141. Similar with prostate cancer, we went all the way from 331 down to 66 when we just compare ourselves with our neighbors. And you can see with melanoma, from 400 excess cases down to 26. Where that didn't happen was with colorectal cancer and lung cancer. So we're very different from the rest of the United States, and we're very different from our neighbors who have similar demographic and behavioral risk factors compared to us. We actually have more excess cases of colorectal cancer when compared to our neighbors, and a similar number here. So lung cancer is not technically or typically high in our neighbors, but we are high in Iowa. So that's just kind of one other way to look at that. When we look at these 5 cancers and trends over time, we can see that, again, a lot of this is happening around that 2013 time period I mentioned before, where we see Iowa's rate of breast cancer going up a little bit higher than the rest of the country, prostate cancer increasing higher than the rest of the country. Same with melanoma, same sort of pattern. Whereas lung cancer, we are decreasing, but we're not decreasing at the rate that the rest of the country is, and that gap is getting bigger over time. And colorectal cancer, we're kind of coming down along with the rest of the country, but our rates are always higher. Here's some of the good news. When we look by stage, like what stages are driving these increases in some of these cancers? For prostate cancer, a localized stage is where it's just limited to the place where it started. It has not spread anywhere. It's not in any other organs or anything like that. So it's usually very treatable with very good survival. So you can see in prostate cancer, much of that increase I showed you on the previous slide is really driven by this localized stage, where you can see a little bit higher in regional. That's where it's gotten in maybe into some lymph nodes or nearby organs, or distant where it's metastatic. It's spread throughout the body, and we're pretty similar in that. So that's a good news story about prostate cancer. And prostate cancer is one of those that the more you look for it, the more you will find it. And sometimes, and the trick is it's impossible to know for who, but sometimes the treatment is worse than the cancer. And so that's where there's a lot of shared decision making and talking with one's doctor about both screening and treatment related to prostate cancer. But it is a sign that people have, good access to healthcare and are finding it early. And I'm sure if you talk to anybody who had their prostate cancer removed when it was early, they're probably very happy they did so. Breast cancer is a similar story. You can see regional, so spreading to the lymph nodes or distant metastatic disease is very close to the rest of the country. Where we see the biggest increases are in those localized cancers. So that's a good news that we're finding it early, and those are very treatable. The hard part of that is, though, that, somebody who's diagnosed with breast cancer, even if they go through successful treatment, they do always have to worry about it coming back. And they often are put on things like tamoxifen or drugs that really impact their quality of life for several years. So when I say good news, I mean better than it be one of the other stages, but still very devastating to people even to have these early stage cancer diagnoses. There is no good news in this picture. This is all bad news. This is the stage distribution for lung cancer. And you can see we are very much higher than the rest of the country in distant stage or metastatic cancer, which is one of the most deadly types of cancers again. It is coming down, but it's slower and it's much higher than the rest of the country. We do see here localized cancer is higher, which that would be the best of the three. But lung cancer is, even catching it early, is still some pretty profound changes to quality of life through those treatments. And then you can see regional, we're still a little bit high in too. So kind of across the stages, but the biggest gap is in distant or metastatic lung cancer. Colorectal cancer is kind of similar to breast and prostate, where we see the biggest difference in our localized cancer. It's a little bit hard to see there, but comparing those lines, regional, or these two purple lines, we're ticking up a little bit, unfortunately, and distant too, we see a little uptick in recent years. And then melanoma, kind of like breast and prostate, is largely driven by localized cancers. And that's great. That's usually minimal morbidity with treatment of localized melanoma. People can go on to live long lives. Unfortunately, once you get one melanoma, you're often likely to get more. So again, it's not to discount how devastating that can be to get that diagnosis, but good news is that it's not driven by these regional or distant cancers, which are very hard to treat once melanoma gets to that stage. Some people ask, well, are we just better screening? Are we doing more screening in Iowa? Is that why we have more cancer? Which is a very legitimate question, one that we had also. The answer is no. I don't think it can account for everything. It may be a contributor, but as you can see, Iowa's screening rates are very similar to the rest of the country, a little bit higher in mammography, which is great. Similar in a lot of these other types of screening. You can see lung cancer screening is very low, and it's very low across the country. And that's one that really has the opportunity to save a lot of lives. It's just one of the newer screening ones. And I think some health system factors and just some logistics to work out to really improve that. The other thing is, if I showed you these screening rates over time, they're not changing much over time. Iowa tends to have good screening rates, but they're very stable. They may inch up a little bit over time, but not in proportion, not like this kind of shape where where screening is going up. That would account for those increases in cancer. Just wanted to point out that studies have shown that 40% of cancers in the US are attributable to modifiable risk factors that include things like smoking, alcohol, diet, infections, physical activity. So those are really important. This part I'm going to bring up some of the major cancer risk factors that often are discussion topics for legislation, which may be of interest to you. When we look at modifiable cancer risk factors in Iowa, can see we still have 13% of people smoking in Iowa. That makes us 16th in the country. There is one study that projects Iowa to have one of the highest smoking rates by 2035, which would not help our situation with lung cancer. That's for sure. As we'll talk about, most cases of lung cancer are caused by smoking. Also quite high, ranked number 2 in the country in binge drinking. So that means people are asked, men who take this survey are asked in the last 30 days, have you had 5 or more drinks on one occasion? And women are asked, in the last 30 days, have you had 4 or more drinks in one occasion? So that means more than 1 in 5 Iowans are answering yes to that question, Iowa adults. We also rank in the middle with no leisure time physical activity. But again, we're talking about more than 1 in 5 Iowans who say they report no physical activity in the last 30 days, like none, none physical activity whatsoever outside their jobs, which is very concerning. And we have a very low percent that come anywhere close to meeting the physical activity guidelines as recommended by the CDC. We rank 12th in obesity. We're usually right around that top 10. We have 38% of Iowans with a BMI above the threshold for obesity. And along with the rest of the country, we are really bad at eating recommended amount of fruits and vegetables. Only have about 7% of people who seem to be or report eating enough fruits and vegetables. Those are really important. Might not sound like that big of a risk factor compared to something like smoking, but really important, like the antioxidants and the nutrients that are in fruits and vegetables can go a very long way in repairing DNA damage from being exposed to potential carcinogens. So it's very concerning when we see that, people are not ingesting the type of food that would help repair the damage and help prevent cancer. Again, when I come back to smoking, it's estimated that smoking causes 20% of all cancers and 30% of all cancer deaths, causes 80% of lung cancers and 80% of lung cancer deaths. And again, lung cancer is our leading cause of cancer deaths, and it accounts for 25% or quarter of all cancer deaths in Iowa. Nicotine can harm the brain development of children and teens, and nicotine addiction often leads to longer-term tobacco use as kids get older. I'm sure, as you're all aware, there's more and more ways to get kids addicted to nicotine these days. And just, if you use cigarettes as directed, 50% of cigarette smokers will die from using those cigarettes. So there's not really any other product that I can think like it in the United States where half of the users will die of either cancer or things like lung disease, heart attacks, strokes, peripheral artery diseases, aneurysms, type 2 diabetes, lower bone density, and causes just other things like gum disease and tooth loss. I bring up all of these are important because often the profile of current smokers, many are low income, many are on Medicaid, and many so smoking can lead to much higher Medicaid spend for all these different types of conditions. And going back to the slide I showed you at the beginning, if you look at all the cancers we're ranked in, I've colored them in yellow if they're associated with where smoking can cause those cancers. And you can see of the 12 cancers listed here, smoking is associated with causing 7 of the 12 of the cancers where we're ranked very highly. So it's not just lung cancer. Other thing I wanted to bring up, is you saw that we have a very high melanoma rate, second highest in the country. 92% of melanoma cases are attributable to UV exposure. And so things like tanning beds, just one indoor tanning session increases a person's chance of developing melanoma by 20%. Using a tanning bed before age 35 increases a person's risk for melanoma by 75%. Tanning bed use may lead to more cell mutations compared to just sunlight, increasing risk for melanomas. And tanning bed users are more likely to have multiple melanomas on areas of the body that typically receive less sunlight. And I thought interesting to point out that back in 2014, the FDA required that labeling included on sun lamp products, which are tanning beds, stated that the product should not be used by anyone less than 18 years of age. Iowa is one of the only few states that really don't have any sort of restrictions on tanning bed use for our minors. Also wanted to point out there are some vaccines that can prevent cancer, HPV and hepatitis B. HPV vaccine can prevent types of oropharyngeal head and neck cancer. That's the one that we are typically ranked #1 in the country for. Also can cause several other types of cancer. If you don't get the virus, you often don't get the cancer. So that's the importance of that vaccine that's been around for 20 years, provides safe, effective, lasting protection against HPV, thus reducing cancer risk. It's recommended at age 11 or 12, and that is the time when kids' immune systems is just in the best place to take that vaccine up and give them protection for the rest of their lives and before HPV exposure. Also wanted to acknowledge the very important role of the environment and chemical substances that we can be exposed to through the environment. The National Toxicology Program, which is within HHS, has identified the chemical substances listed below as human carcinogens. I'm going to leave a lot of that discussion to my colleague, Dr. Swartney, who's up after me and is going to talk a little bit more about cancer in the environment specifically, but I did want to say just a few quick words about radon before I end here. Radon is the #1 cause of lung cancer among non-smokers. So smoking, obviously the #1 risk factor for lung cancer. Radon is #2, and it is #1 among non-smokers. Iowa has the largest percentage of homes above the US EPA action level 4. We also lead the nation in percent of homes over 20, which would be, obviously 5 times the threshold for which those levels can contribute to cancer. Average indoor radon concentration in Iowa is at least 6 times the US average, and it's a little bit variable by county and even within county, even within a block. It just kind of depends on the structure of your house, how tight and how new those houses are, the construction of those, how much time people spend in their basements, all kinds of things can kind of make that a little bit variable, but really important to encourage testing and mitigation in Iowa homes. And important to note that people who smoke are exposed to, and people who smoke and are also exposed to radon are at 10 to 20 times higher risk of developing lung cancer than non-smokers. So that is all I wanted to cover before I turn it over to Dave, and happy to take questions at the end.
Thank you so much, Dr. Charlton. And as Dr. Charlton said, we will have time for Q&A again at the end. You're welcome to use the Q&A function on Zoom here if you want to go ahead and get your questions down, or the chat. Either way is fine, or save them for the end is fine as well. And with that, I would like to welcome Dr. David Swartney to talk to us about water quality. Thanks, Dr. Swartney.
Thanks. Thanks to the organizers for having me here to talk about this issue, and for the candidates and their staff to attend to hear about where the current state of things are with our understanding of water quality and cancer. My name is David Swartney. I direct the Center for Health Effects of Environmental Contamination, which is a state-funded research center. I'm also a professor of civil and environmental engineering and chemistry at the University of Iowa. Any conversation about cancer and drinking water needs to start with what we regulate under the Safe Drinking Water Act, which applies to community water systems or public water systems that serve, say, cities or communities. We do regulate certain things for their known ability to increase risks of certain forms of cancer. Primary among these are disinfection byproducts. These are things that form incidentally as a result of our use of things like chlorine to kill bacteria and other pathogens as the final treatment step in drinking water treatment. We know we can form things like trihalomethanes, which are known to increase rates of certain forms of cancer. Everything else on this list that I've highlighted in brown are the ones that I think are probably most Iowa relevant. You see that we have naturally occurring substances like radionuclides and certain forms of metal like arsenic that are present in our groundwater for any community that's relying on groundwater as their water source. We do regulate a lot of what we call organic chemicals or carbon-based chemicals, but there's not many known for their ability to increase cancer risks that are actually regulated for that reason. Alachlor is one. We don't even use it much in the state anymore. It was LASO. Notable things that aren't on here that are regulated in drinking water, like atrazine and glyphosate, aren't regulated for their ability or their known expectation to increase cancer risk, but for other known adverse health outcomes. One of the other things that's not on that list that you may have noticed is nitrate, and nitrate is at the front of many Iowans' minds. Nitrate is regulated in drinking water along with nitrite for their ability to interfere with how oxygen is transported in the blood. Most Iowans are aware of our 10 milligram per liter as nitrogen standard for nitrate. We do this because if there's too much nitrate, say in formula that's used to feed an infant, the nitrate can interfere with hemoglobin's ability to deliver oxygen in the body, and the infant can become oxygen deprived. They turn blue, so this is frequently called blue baby syndrome. The technical term is methemoglobinemia, and in really extreme cases, it can lead to infant death. But we do not regulate nitrate for any concerns over long-term cancer risk or chronic health effects. The challenge in Iowa is that there's been a lot of research, including research done in Iowa by the previous director of my center, that has found associations between nitrate in drinking water and certain forms of cancer. And so this would be long-term exposures from 4 to 10 years in these epidemiological studies, where increased risks with bladder, ovarian, and thyroid cancer have been observed at nitrate levels in drinking water that most notably are below that 10 milligram per liter standard. These types of studies have been replicated in other institutions, including those around the world. And Pete Weyer, who was the prior director, along with researchers from the National Cancer Institute, wrote a review sort of summarizing what the available literature is back in 2016 and did note this common observation from epidemiological studies of increased risks of certain forms of cancer like colorectal cancer, thyroid disease, and birth defects, and oftentimes at nitrate levels in drinking water that are below the 10 milligram per liter standard. Because this is something that's gotten some discussion lately, I think it's important to point out that we know nitrate in drinking water can be an important source of nitrate when you think about other sources that might come from diet. This is research that my associate director at Cheek, Darren Thompson, did with researchers at the National Cancer Institute. And what they found is that when private well users are drinking nitrate in drinking water close to that 10 milligram per liter standard, nitrate from drinking water can make up almost about half of their dietary of their nitrate exposure when you account also for their diet. And so it speaks to the importance that we do need to be mindful about nitrate that we get exposed to both through food as well as water. Many people ask what nitrate in drinking water, if we're to believe this epidemiological data, would translate to in terms of number of cancer cases per year. The best study to date was done back in 2019 by these researchers at Group. And I want to acknowledge it was also done with the Environmental Working Group, which is an advocacy group, but it did pass peer review. And they calculated, using the best available data and risk factors associated with nitrate exposure, what would look like the total number of nitrate attributable cancer cases through drinking water, with most of these, 50 to 80%, being colorectal cancer. In the United States, they estimated anywhere between 2,300 and 12,594 additional cancer cases from nitrate in drinking water. They actually extended this down to the state level, and I wanted to share this specifically because in Iowa, the estimated range was from 74 to 332. And the reason there's a range is you're accounting for potential uncertainty in the type of epidemiological data that's been collected, and you are making the assumption that there's this plausible connection between nitrate exposure and drinking water that could lead to certain forms of cancer. But if you remember the numbers that Dr. Charlton just presented, we have about 2,500 excess cancer cases in Iowa. And so even if nitrate were contributing, and there might be some mechanisms that others have proposed, thinking about other byproducts that can form through nitrate ingestion that could lead to things like cancer, it would not explain the majority of our cancer burden. And I think that's an important piece to keep in mind when we think about environmental factors and the role that nitrate could play. The other part that's been frustrating, I think, to many Iowans is that the EPA back in 2010 acknowledged this new information, that there was new data about these chronic health effects like cancer and birth defects that might require a revision of the maximum contaminant level standard under the Safe Drinking Water Act. And back in 2010, as part of their formal review of the standards, they requested a new health assessment. As of today in 2026, that health assessment has not been completed. It has been started and stopped. And so I think we find ourselves in this limbo where the EPA acknowledged there's new data that might require a more stringent standard for nitrate, but they have not been able themselves to do the necessary health assessment to make the case. And so the question that we're up against is Iowa's drinking water safe enough? We have about 800,000 to a million Iowans every year that have drinking water served to them above 5 milligrams per liter in nitrate. And you see that many are deciding to choose things like reverse osmosis in their homes to provide extra layer of protections while losing confidence in their tap water. And this doesn't even account for the large number of Iowans that we have on private wells that are unregulated and fall outside the Safe Drinking Water Act. We have good private well testing data through the Private Well Grants Program. We know that anywhere between 10 to 12% of all nitrate tests in that database exceed the 10 milligram per liter standard, with a large number more above 10. And I think private wells are a particularly important consumer group that we need to be focusing on when we think about exposure to potential cancer-causing substances in water, largely because our groundwater is vulnerable to what we know are naturally occurring cancer-causing agents like arsenic, uranium, and radium. The Private Well Grants Program started testing for arsenic back in 2016, and I'm showing you the map where we know we have arsenic broadly distributed in our aquifers. And our best estimate, although we're still cleaning the data, is about 10% of these tests would exceed the EPA MCL if that applied to private wells. More importantly are the number of counties that aren't yet testing. You see those white gaps. We have folks that might be getting exposed to arsenic through their drinking water, and they don't know it because we aren't testing enough. Another emerging threat are PFAS forever chemicals that you might have heard about in the news. And so we see through Iowa DNR testing that folks that are concerned or that are most vulnerable to exposure to PFAS in drinking water are along the Mississippi River. And I do believe that's an area where we need to be focusing more attention as these become more of a problem and they start to be regulated under the Safe Drinking Water Act in 2031. Many Iowans are rightly concerned about the heavy use of pesticides in our agricultural production system, and I think it's worth acknowledging that we do use a lot of chemical ingredients on the land, and we're densely concentrated here in Iowa when we think about our use maps and where we see a heavy combination and use of pesticides. I worry less about pesticides in water than I do about the drift leaving these farms in air. So this is just some example of the data we collected Cheek, where we've sampled leaves in downtown Iowa City, and I'm showing you the range of herbicides and fungicides that we can detect on leaves in an urban area. It's not because we're applying herbicides and fungicides in these areas. It's because we're heavily using them in fields that then get drifted over into communities, leading to potential exposure routes. And so when we think of things like lung cancer, and we're worried about what role pesticides might play, the greatest risk for pesticides is usually always with the applicators that get the greatest degree of exposure. But I do believe there are some broader exposure scenarios that we're not fully considering because we don't have sufficient monitoring. I'd like to end just by talking briefly about what other states are doing. Wisconsin does a much better job of communicating risks and uncertainty around nitrate. Rather than thinking about it as a pregnant mother or infant problem, it talks about how high nitrate can affect everyone, potentially through birth defects and colorectal cancer increased risks. Nebraska's increased funding for point-of-use treatment devices that well users could use in their home to reduce their exposure risk. Nebraska has also invested heavily in research to understand their burden, and there's been important outcomes of potential risks from combined exposure to nitrate and atrazine. And we just need more environmental monitoring because we don't have sufficient data to make the links that many Iowans are looking for. And this isn't just the sensing network, it's about making sure we have the state-of-the-art instrumentation and personnel at the state hygienic lab to look for emerging threats that are unique to Iowa. With that, I'll end and I'll happily take any questions you all have in the Q&A session.
Thank you so much, Dr. Sortney. We really appreciate that. And next up, we are pleased to welcome Dr. Whitney Zond, who is going to talk to us about access to cancer care. Dr. Zond?
Thank you, Kelly. So my name is Whitney Zond. I'm a faculty member in the Department of Health and Human Service, Health Management and Policy um, here at the University of Iowa. I talk about the Department of Health and Human Services, so I got a little bit ahead of myself. But I'm also Deputy Director of the Rupri Center for Rural Health Policy Analysis as well. And I'm going to be talking a little bit about access to care. And this is going to focus on access to care broadly, but also when we talk about access to care in a broad sense, that's going to have applicability for cancer care specifically as well. So when we think about barriers or things that may prevent people from getting cancer screening and care that can be addressed at a policy level, there are three areas that I think are really important for us to think about. One is workforce and access to healthcare facilities. Others, and tied to that is that distance to those services. So when we think about access, often we think about access as a, how far is it to the oncologist or the hospital or the primary care provider who you may be seeing. So that is a key part. And with that, transportation can play an important role as well. Another key piece of access to care is how is that care being paid for? And often that, obviously insurance plays a key role in that. And so I'll speak a little bit to that, particularly around Medicaid and the marketplace, the health insurance marketplace, which is an important source of how people who do not have employer-sponsored insurance or who are not eligible for Medicaid get access to insurance that will cover their health care broadly, and then as well as for cancer care specifically. So we think and talk about access to cancer care. This is a map, courtesy of Amanda Call from the Iowa Cancer Registry, showing where Iowa's hospitals are throughout the state. But I particularly want to highlight a couple of items on this. You can see in the darker green, those are our metropolitan counties as we define them based upon the United States, the U.S. Department of Agriculture's Rural Urban Continuum codes. And then the lighter green, lighter greenish blue are the more non-metropolitan counties. So you can see here, there's a few of these yellow triangles throughout the state. These are Commission on Cancer accredited hospitals, which are hospitals that have received accreditation from the American College of Surgeons based upon their focus and the infrastructure and their efforts around providing high quality cancer care and reporting quality and assessing quality in those. So you can see currently where those are located throughout the state, as well as our National Cancer Institute designated cancer center here in Iowa City. And then, obviously other hospitals throughout the state. But when we think about the highest quality cancer care, this is where they are located. As you can see, currently, those are in mostly more urban areas. And there are some efforts underway that Dr. Charlton is leading to provide support for some of our rural hospitals to also get that designation. I also want to note, just by way of showing where we have access to care in our rural parts of the state, this is a map from the Rural Health Information Hub. Obviously, in the previous map, that's defining rural and urban based upon county. But I think this is another helpful way where we just have our more urban areas shown in this tan, our metro areas. So you can see outside of those are our more rural areas, and that includes primary care services such as Medicare certified rural health clinics and federally qualified health center clinic sites that are located in our rural areas. Those are important sources of primary care where individuals can get education around cancer prevention and screening, can receive some screening and or receive referrals to screenings, or receive their survivorship care following elements of their survivorship care following their treatment. And then, of course, our hospitals that are located in rural areas, as well as you can see with the blue diamonds and orange circles as well. So I want to talk a little bit about Medicaid and then the marketplace. So nationally, 1 in 10 adults with a history of cancer are covered by Medicaid, and 1 in 3 children. So this is an important source of coverage for those who had a history of cancer. For those individuals, there can be barriers in accessing providers who may accept Medicaid. There can be challenges with coverage gaps or the administrative burden of as we get into more work requirement reporting to receive that coverage. Can be delays in prior authorization that can be potential barriers when it comes to this. And I also want to note just the number of individuals in the state, more than 600,000 individuals, children and adults who are enrolled in Medicaid currently. Also want to note the marketplace insurance plans. So these are plans that folks who do not have employer-sponsored insurance, who are not eligible for Medicaid or Medicare, this is where largely where they're going to go for their coverage. So with this, there have been previously some tax credits for purchasing this marketplace insurance. So these are plans that they purchase independently. Some of the tax credits for these have expired. There still are some available for some folks, but that can make that more expensive to purchase, higher premiums. There's also the challenges if some of these insurance plans have high deductibles. So if folks are covering, paying for their appointments and those things, those can have to reach that deductible before other parts of that kick in, or might have high co-insurance. There can be challenges sometimes with the networks available and other coverage gaps. I wanted to highlight marketplace insurance as a key source of coverage because such a high percent of farmers, as an example, 27% of farmers rely on marketplace insurance. And this is a source of coverage for over 120,000 Iowans as of this year. This has gone down a little bit since last year, but it still is an important source of coverage. Again, of course, people are on Medicare or have employer-sponsored insurance as well, but wanted to highlight that. Another thing I wanted to note as we think about rural cancer care and just in policy and in rural health policy is the Rural Health Transformation Program, and Iowa's application includes elements around focus on combat cancer, prevention and treatments. I just want to share a little bit about that just by way of information. But more broadly, this was part of the One Big Beautiful Bill Act that was signed over the summer. That will be $10 billion a year over the next several years. And Iowa's allocation for this fiscal year is over $209 million. And what this breaks down to in the realm of cancer, just to share, are some technical assistance provision around cancer health hubs, and you can see what that is out to as far as providing technical assistance and support to hospitals in rural areas. Some funding around radon testing and mitigation, resources for colonoscopy and other forms of colorectal cancer screening, and other technology aimed primarily at cancer screening and prevention. And then also some funding to the University of Iowa Cancer Partnership, again, extending some of the work that Dr. Charlton mentioned that the state has funded, expanding the ICANN program, which, as I noted earlier, some of the work around supporting rural hospitals to become Commission on Cancer accredited. So those are the main things I wanted to highlight this afternoon, but I'll be happy to answer questions later. Thank you.
Thank you so much, Dr. Zond. Appreciate that. And our final speaker today is Dr. George Weiner, who's going to be talking to us about cancer research. Dr. Weiner.
Thank you. So it's indeed a pleasure to talk to you, and I'll talk a little bit about myself later on in the presentation. I am speaking as an individual and not on behalf of any organization. And in fact, I'm going to be speaking to you from a number of different perspectives today. I am an oncologist and a cancer doctor who's been caring for cancer patients in Iowa for over 35 years and also doing cancer research during that time. I served for 23 years as the Cancer Center Director at the Holden Comprehensive Cancer Center, and I'm also a cancer patient. And I'll touch a little bit on how research has impacted on my own cancers as we move along. Now, when thinking about cancer research, people sometimes say, what are we talking about? And we're talking about basic research, trying to understand the nature of cancer and how it interacts with the body. We're talking about clinical research, where we take those discoveries and try to improve cancer care. We're talking about population research, where we deal with populations of people similar to the work that Dr. Charlton is doing. And then we talk about implementation research, where we're looking at better ways to take what we already know so we can reduce the burden of cancer for those who we serve. And each of these can impact on cancer prevention, early detection, therapy, and quality of life. And Dr. Charlton showed you some of the data showing the pretty significant national drops in cancer mortality, including in Iowa. And that has resulted actually in an increase in the proportion of Iowans who are cancer survivors. And I now count myself as one of this group. And this is data that Mary's team helped to generate. Now, when we think about the ways we can reduce the burden of cancer for Iowans, we've talked about the two of them this afternoon. We've talked about cancer control, where we do everything we can to assure all Iowans benefit from what we've already learned as far as HPV vaccines, not smoking, environmental factors, etc. At the same time, we need to support research into improved approaches to cancer prevention, early detection, and therapy. And the fact is, when it comes to cancer research, we are making progress faster than ever before, both with respect to discovery, what we're finding, but also with respect to our ability to use that information to help patients in ways we couldn't have imagined just a few years ago. My own research is in cancer immunotherapy. And when I started out in that field, it was considered a pipe dream. And many of the experts said, you can never use the immune system to treat cancer. Well, now over a third of cancer patients are getting cancer immunotherapy. And we're helping people we couldn't have imagined that we'd be able to help just a decade ago. The fact is, these advances are based on support for cancer research that's been made over the past 2 decades. And most importantly for today's investments will impact on the burden of cancer for our children and our grandchildren. So we must keep investing in cancer research in order to reduce the burden of cancer for those who will come after us. Much of the support we get for cancer research comes from the federal government. Competing for that funding is much harder than it ever was before. And you can see a curve showing the levels of research funding. And the way the system works is when a researcher has an idea, they will write a grant, very often spend a huge amount of effort describing how they want to pursue this idea. And that grant is then submitted for peer review, where experts will review it and rank it. Either it's the very top 1%, maybe it's the 20th percentile. And then those rankings are reviewed by the National Cancer Institute or foundations or other groups, and only the very best are funded. Well, last year, there were some grants that fell in the 5th percentile. In other words, better than 95% of all the other grants that were submitted that were not funded. And so this means, yes, we're making progress faster than ever before, but there are also a lot of great ideas that are being left on the table. They're being left in the field, and they're not being pursued. In Iowa, we receive about $24 million per year from the National Cancer Institute for cancer research funding each year. And we also get funding for cancer research from other branches of the federal government, other branches of the National Institutes of Health, Department of Defense, Center for Disease Control, etc. What has been recognized around the country is that in order to compete for the funding, because that competition is so difficult federally, that state funding can help prime the pump and help researchers in the state not only make progress in their cancer research, but also make them more competitive for federal funding. And by chance, a report just came out from the Association of American Cancer Institutes this week that describes the status of state funding for cancer research. And the link is here, and I believe Kelly said she could add that to the chat as well. And here's a summary of some of that data. If you look at the states that provide state funding for cancer research, you can see some of them are in the hundreds of millions. And this is states that tend to be red states and blue states as well. Iowa is low down on this list. And that $1 million is very valuable, and it's been helping the epidemiology team try to understand our second in the nation in cancer incidence. But compared to other states, this number is really quite low. How is this funding being used by the other states? As I said, it's being used for pilot grants. So researchers there can be more competitive when they submit grants nationally. They're more likely to get those grants if they can show good preliminary data that they're making progress. They're used to recruit researchers and cancer doctors. And in fact, we've lost some recruits to Iowa who wanted to come here, and we wanted them here. But the amount of money being offered by some of these states for them to do their research was too much for them to turn down. And in some places, some states support clinical research infrastructure, including that helps support clinical trials. So these are all areas I think the state of Iowa could really benefit if we were to invest more extensively. Cancer research support comes from, as I said, the federal government. It also comes from philanthropy of grateful patients and others, foundations that support our research, collaboration with industry and health systems such as the University of Iowa Healthcare, and state government. But the fact is, each of these groups has a role to play. And I've been asked, well, doesn't the federal government support all this research, or don't pharmaceutical companies do so? And the fact is, we really need to have all hands on deck if we're going to make the type of progress for our children and grandchildren that I see us able to make. Now, in the last couple minutes, just going to talk a little bit about my own story. As I mentioned, I joined the faculty at the University of Iowa in 1989 and initially split my time caring for cancer patients and doing cancer research. I was fortunate enough to get institutional support and to get foundation support and support through the VA and then the National Cancer Institute. And that research has continued. And over the years, I've been able to get grants that have brought $120 million in support into the state. So that's, I think, been a huge economic boon for the state, in addition to improving the quality of healthcare and making research progress. And as I mentioned, my research focuses on cancer and the immune system. In addition to my serving as director of the Cancer Center for 23 years, I served as the president of the Association of American Cancer Institutes, chaired the committee that reviews cancer centers for the National Cancer Institute, and was honored to be the founding president of the Iowa Cancer Consortium. So I've gotten to see the incredible progress we've made in cancer research over the past 20 years, 30 years in these various roles. And in fact, I have become a beneficiary of that progress. I have 2 cancer diagnoses. I was diagnosed about 7 years ago with early stage prostate cancer. And 10 years before that, I would have had my prostate removed. But due to research, it became clear that my cancer was indolent behaving enough that we could just monitor it. And I'm very pleased to say that it has remained quite stable. And so we've saved the health system money by me not having to have my prostate removed. And I'm grateful that I still have it as well. And just 2 months ago, I was diagnosed with a second cancer known as smoldering multiple myeloma. And with this new diagnosis, this has the chance of turning into an aggressive myeloma in just in of about 30% in the next 10 years. But if that happens, the treatment advances we have made are amazing. And I'm confident that I'll be around for many years to come despite these diagnoses. So I've seen it. As a doctor, a researcher, administrator, and a patient, that cancer research saves lives. It improves the quality of life, supports the economy, makes Iowa more competitive, and it touches us all. And I think the time is right for Iowa to invest more in cancer research. So I will stop there and looking forward to the Q&A.
Thank you so much, Dr. Weiner. It is so appropriate to end with a personal story of cancer, because ultimately that is what we are all working towards, to make that experience better for Iowans. Hopefully who won't have to face a cancer experience, but better for the Iowans who have faced a cancer experience. So thank you for sharing that. And thank you to all of our experts today. You are such a great example of the expertise and partnership that's available through the Iowa Cancer Consortium. So thank you for your expertise. Do you see my presentation slide again, Megan? Okay, great. So very briefly, I am going to talk to you about the Iowa Cancer Plan. I think it's pretty clear, hearing from our experts, everything we've talked about today. It's obvious how complex cancer is, and we really haven't even come close to being able to touch on everything. With this complexity, it can be very, very difficult to know where to start or what to do to begin to address cancer as such a big issue and so complicated. That's why I want to share with you this tool that we have, thanks to the cancer control work here in the state, the Iowa Cancer Plan, which is an evidence-based roadmap for steps towards a reduced burden of cancer. The Iowa Cancer Plan isn't a strategic plan specifically for the Iowa Cancer Consortium alone, but rather it's really intended to be used by anyone in the state who is interested in working on cancer control. The plan is aligned with both national and state sources for cancer-specific data and goals. It includes 5 chapters which span that cancer continuum that I mentioned earlier. And it contains recommended actions that have been shown to be effective, and again, that can be completed by policymakers, communities, individuals, advocates, truly anyone who wants to help reduce the burden of cancer here in our state. And really, it makes a lot of sense in cancer control to start with what has been shown to work through research efforts like Dr. Weiner described, while we are still continuing to do research to understand even more about what works. And the cancer plan is full of guidance about what does work and where to start. Very quickly, I just want to show you 3 screenshots just so you can understand what to expect to find in the cancer plan and how to navigate it, so that you can get a feel for what the content is like. The pieces shown here are from Chapter 2, which addresses cancer prevention, and Priority 1 within that, which is about reducing exposure to tobacco and secondhand smoke. You can see there are clear strategies and several action steps found under the priorities. And the priorities or the strategies themselves also include numerous tactical suggestions for addressing each particular issue. This is really just one example of a very robust plan that can provide guidance for where to start and what to do to work on cancer. And you'll also find in that 3rd screenshot there, you'll find data targets throughout the plan that are associated with the priorities. And with that, we are wrapping up the presentation piece of our time together. I do want to encourage everyone to stay connected with the Cancer Control Network here in the state. You can do that by hopefully completing the survey that we'll send you later. And again, we don't want anyone to feel like they don't have the resources or don't have questions answered in order to complete that survey. So please feel free to reach out for continued conversation. You can sign up to receive emails and learn more at canceriowa.org. You can find us on social media. We have a virtual spring meeting happening next Tuesday that you are welcome to attend. That will be a wonderful showcase of more localized and some statewide cancer control that's happening here in the state. You'll hear it from the folks who are implementing it themselves. And of course, we welcome you to join the Iowa Cancer Consortium. We do have policymakers who are members of the consortium. And as we've talked about, it takes all of us. It takes cross-industry partnerships in order to truly move the mark on cancer prevention and control. So we would welcome your membership as well. With that, we will stop the recording, Megan, and move into our question.